Well, thank you so much for inviting me. Thank you for organizers and to Mark Kubicki for making it possible for me to talk to you today. So as an introduction suggested, I will be talking about fMRI-based neurofeedback and how can it be used actually for two purposes. One is for testing certain neuroscientific clinical theories, and another as a clinical tool. Whoopsie, this is not what I planned for. Okay, this way? Yeah. All right, so let me introduce neurofeedback as a concept first. And neurofeedback as such, I think, has been introduced for quite some time. However, fMRI-based neurofeedback is a fairly recent concept in terms of how we can use this technology to deliver information about the function of the brain to the person in real time. So there are two ways in which we can do it, in which studies are designed. Very many studies, what they do is that they pretty much put the person into an fMRI environment, into a scanner, and they request them to change typically the activation in a specific brain region. The feedback that people get is usually in the form, of a graphic representation where different groups come up with different ways in which you can show somebody how well they are doing in the task they are asked to perform. Another way of approaching neurofeedback is by actually teaching people a specific task that we know from prior studies should impact the brain region in which we are interested, and furthermore, the task can impact this brain region in a way that we believe can be therapeutically advantageous. And actually, this is the approach that we have taken in our studies. So the studies that I'm going to present to you are going to rely on this sort of approach. So there are, when we talk about the possible targets for neurofeedback, there are typically two main targets. One, we are attempting to change activation levels in specific brain regions, or we are trying to impact functional connectivity also in specific brain regions. Typically what happens, and I'm going to show it to you in our data, is that both of these phenomena actually happen during the neurofeedback session. In terms of the goals, as I mentioned before, we can use neurofeedback to test our hypotheses about specific cognitive construct, clinical construct. Typically, the way we design neurofeedback studies is by understanding, to the extent that it's possible, how a certain clinical condition can unfold. And we construct our study based on this understanding. So obviously, if our intervention works, it's a confirmation that indeed what of the theoretical framework that we are using is correct, and we typically are able to further elaborate on it and enhance. And another very important goal, obviously, is to improve clinical symptoms that people can suffer from. So in terms of a number of studies specifically in psychiatry, the recent meta-analysis suggested that there are 31 studies altogether, and not many of them are actually in schizophrenia. There are 8 published studies. I think it will be 9 with our studies, which was most recently accepted, actually. And at this point, it looks like about half of them actually come from our group. So in the studies that I'm going to be talking about, we have focused on, for one, on schizophrenia, and second, we specifically targeted auditory hallucinations as one of the more troubling features of schizophrenia. So just to kind of, as an overview, auditory hallucinations are defined as these sensory experiences where people hear voices in the absence of external stimuli. Usually, they are associated with mental illness, although not always. There are circumstances in which people experience auditory hallucinations outside of mental illness. They are usually complex. They either include single words, sentences. They are often emotionally charged, and what is interesting, the majority of auditory hallucinations are negative in nature, although actually we have worked with some people who had very positive auditory hallucinations, so which poses an interesting dilemma of what to do if you want to get rid of those. So across different studies, there were a number of brain regions which were suggested to be involved in auditory hallucinations. They include temporal regions such as Herschel gyrus, mediotemporal lobe, bilateral superior temporal gyri, inferior frontal gyrus, as well as midline structures belonging to default mode network, including medial prefrontal gyrus and posterior singular gyrus, as well as dorsolateral prefrontal cortex. So our core assumptions in our studies that we kind of relied on are that, first of all, it is possible to bring brain-specific changes using neurofeedback, that these changes are going to result in clinical improvement. Furthermore, we believe that complex clinical symptoms are going to, in fact, involve a brain network rather than just one specific brain region, which is responsible for this constellation of symptoms which come with auditory hallucinations. And also critically is that if we target a specific brain region which belongs to a brain network that supports auditory hallucinations, then the changes that we are going to see are going to actually be seen in the entire network, not only in the brain region which we target, but also in these other brain regions as well. So, as I mentioned, this is kind of the construct that we kind of started with, where we believe that the temporal regions, the midline regions of the default mode network and dorsolateral prefrontal cortex would be the regions which can be involved in auditory hallucinations. And what typically we observe in studies that focus on auditory hallucinations is that in terms of activation, there is increased activation in temporal brain regions. There is also heightened connectivity within default mode networks. So there is this kind of super connectivity in brain regions within a default mode network, specifically MPFC and PCC. I'm going to present actually two sets of studies. In one study, we were targeting superior temporal gyrus. And here what we have done is that we presented people with a task where they were supposed to ignore voices which were coming from a stranger, which were not their own voice, and pay attention to these sort of voices which were their own. People had these voices delivered over headphones during the session. And another task, what actually we have done, is that we introduced a type of meditation called noting practice to reduce connectivity, within MPFC, PCC regions. So this is kind of the design for our studies, and what we have done is that we start with clinical assessment, which is followed by the first session where we localize brain regions which we are interested in then providing feedback from. So in this particular case, we localized for each person, we localized superior temporal gyrus, actually motor cortex, and also DLPFC. And so then what we have done is that actually we taught people mindful task, which is called note in practice. And then finally, with that in place, we divided people into real group who would receive a neurofeedback from the brain region which is involved in auditory hallucinations, and then sham group, which would receive their feedback from motor cortex. So people then went on to their neurofeedback session based on their sort of group assignment, which was followed by the assessment of their auditory hallucination levels. And then what we have also did, partly because we were curious and partly because I was guilty to confuse people in terms of the type of experience they had, is that we actually switched the people who were assigned to sham would get actually real neurofeedback after their sham session. And again, we would follow up with measures of auditory hallucinations. So this is the SDG study where we focus on superior temporal gyrus as our target. And again, as I said, people were supposed to listen to their own voice and to pay attention to it. And they were supposed to ignore other voices, as well as all noises coming from the magnet in the ignore condition. So this is kind of another schematic just to show you how such session would look like, with feedback being delivered in the form. I'm trying to have a pointer, but I don't think I'm having any. No, pointer is this. Well, never mind. So anyway, so the first example is when people correctly increase activation to their own voice. The second example is when the people correctly decrease their activation to other voices. And the third one is when people incorrectly increase activation when in fact they should be decreasing, focusing on decreasing activation. And I have, okay. So these are the results from the SDG focused neurofeedback session, and here I present the whole brain analysis. So first of all, the interesting part is that we looked at auditory hallucinations pre and post neurofeedback, and actually both groups, both the real neurofeedback and the sham group, actually showed reductions in auditory hallucinations, which is interesting and actually understandable in the context of the effects that we have seen in our study. Mm-hmm. And I would like to move on. I have trouble to move forward. Yeah, it is this one. Okay. Can you go back one? Like one back. Okay. So the first result that I'd like to point to is that we had activation and changes in activation post neurofeedback in the secondary auditory cortex, and in such a way that these activation changes, reduction in activations, was observed in the real group, but not in the sham group. But what was also interesting is that when we switched the sham group into real session, which is this next panel, is that actually people also here experienced reductions in activation in secondary auditory cortex, and not people in the sham group. And, secondly, we also have seen actually changes in connectivity, and actually connectivity changes were between actually dorsolateral prefrontal cortex and secondary auditory cortex, which was kind of interesting, suggesting that again, as I was suggesting, the phenomena that we studied really was circumscribed just to one brain region, but really was related to network-wise changes. And again, this similar pattern emerged where these reductions really happened in the real neurofeedback group, but not in the sham group. And again, when we switched the sham group into real group, the pattern of results was similar to what we observed in the sham group previously. Now, since this is whole brain analysis, we also looked at the dorsolateral prefrontal cortex. And here, what was really interesting is that actually activation changes existed for the sham group, but not for the real neurofeedback group at all. So the two groups clearly went about the task in a very different way, and kind of differentially deployed the way certain parts of the brain worked. Finally, for connectivity, actually we went back to this kind of more prevalent effect where actually the changes in connectivity between STG and dorsolateral prefrontal cortex and STG and anterior cingulate cortex actually were observed in the real group, but not in the sham group. And again, when we switched, similar pattern emerged for the sham group as it was for the real group. Finally, we also looked at the connectivity changes between MPFC STG, and which again existed for the real group, but not really for the sham group. And what I'm showing actually here is actually single subject effects where you can see that these reductions really exist in the real group, but not at all in the sham group. And finally, we also had connectivity changes between MPFC and PCC. Now, when we look at the relationship between different brain changes and reductions in auditory hallucinations, they really emerged only for the group, for the STG and dorsolateral prefrontal cortex group, not any other connections that we have observed. So with that, I'd like to move to results which actually we have for this other study, where we didn't aim at STG, we aimed at DMN, and default mode network. And what we have done is that, as I said, the task here was the type of meditation called Note in Practice. And what it really is, that what we ask people to do is to engage in noticing different types of sensory experiences, whatever comes to them and whatever is kind of at the forefront of their consciousness, of consciousness, awareness. And again, this is the schematic how this type of study looked like. And here we actually used, in terms of the feedback that we designed for people, is the one that people really liked a lot, because what we have done is that we had these like large red hoop or red circle, large blue circle, and kind of a smaller white circle. And what we ask people to do is to put the ball in the red circle. And they could do it if they could actually dissociate between MPFC and DLPFC. So this sort of the stronger kind of anti-correlation was between MPFC and DLPFC, the better they were able to put the hoop, sort of the ball into the red hoop. So people kind of felt how they were playing ball with their own brain, and for most people, that was a kind of very rewarding experience, including the fact that a lot of people with schizophrenia really don't feel like they have control over their brain. So their kind of immediate comment was that, well, here I could see for the first time that I could control my own brain, which was, again, a positive experience for them. So these are the results from this study, where again, in the real neurofeedback condition, we observe reductions in connectivity between several brain regions, which is MPFC-PCC, MPFC-DLPFC, and MPFC-ACC. And again, this type of reduction is lacking in the sham group. So also we have looked at the sort of correlations between reductions in auditory hallucination score and the brain measures. And here, STG-MPFC connectivity emerged as being related to reductions in auditory hallucinations. So what these studies suggest is that, first of all, you can use neurofeedback to reduce auditory hallucinations in people with schizophrenia. It is also our hypothesis that by targeting one brain region, we can really affect the whole network has been confirmed. So indeed, when people do neurofeedback, and even if they focus on just one brain region, it doesn't appear the case that this is one region which is being affected. It really is the entire network which is changed. Also, we have noted specific associations between reductions in auditory hallucinations and reductions in connectivity. And so for me, the way this is interesting is that the two brain regions with which auditory sort of regions were connected were both MPFC and DLPFC. And both of these regions, they actually play very specific roles in some of the sort of cognitive functions. MPFC being responsible often for the distinction between self and others, between kind of the notion of sort of where is my boundary and where is this of the world outside of me, and kind of self-referential thinking. And DLPFC obviously is involved in all kinds of control mechanisms. So you can actually see how the interactions between the brain region, which carries kind of sensory information, such as secondary auditory cortex, interacts with these higher order cognitive sort of brain regions, resulting in this really complex phenomenon, which is auditory hallucinations in this case. So I think that with that, we can sort of at least sort of suggest that there is indeed a brain sort of network region which supports auditory hallucinations in all their richness, which is both the kind of the auditory experience, but also emotional experience, kind of lack of control, the sort of inability to distinguish between sort of is it my thought, is it coming from me, or is it coming from outside, sort of outside world in the sense of commentary. Different people in our studies have different levels of self-awareness, but at least one person with whom we worked commented that after this a series of studies and series of neurofeedback sessions, he felt that the voices that he heard moved from outside of his consciousness to inside of his conscious mind, whatever it meant for him, which was kind of a really, really interesting way of describing this sort of experience. So in terms of what we are working currently on, obviously neurofeedback using Fmri is a very expensive proposition. So we actually are working on ways of translating what we know, what sort of, we have discovered within the realm of Fmri-based neurofeedback into EEG by kind of identifying EEG, parts of EEG spectrum, which kind of corresponds to bold activations that we observed within the Fmri environment. Also, what I have done is a kind of, these studies are focused on, obviously, on people with schizophrenia. My next study, which is funded, and we are about to begin, actually will work with people at clinical high risk. So we believe that here we also can introduce positive changes in people who did not yet experience schizophrenia. And finally, and I don't really have time to talk about it too much, it seems that the approach that we use may have actually transdiagnostic value in the sense that you can use it not only in specifically, for example, in schizophrenia spectrum, but also in bipolar disorder, in anxiety and depression. And with that, I'd like to thank my collaborators, without whom this study obviously would not be possible. Thank you so much.